I will now turn the webinar over to our presenters. Ms. Jacqueline Garrick is joining us today from the Department of Defense, where she is the Director of Defense Suicide Prevention Office, and Dr. Caitlin Thompson, who is the Deputy Director of Suicide Prevention at the Veteran Health Administration. Thank you for joining us, and let's have the webinar begin.
All right, thank you for inviting us to participate in this important forum for educating future physicians of the world. I think this is a key opportunity for us to be able to talk about our unique populations who are on active duty, the Guard, the Reserve, and then, of course, Caitlin will follow up with our veteran community. So there's sort of a progression here of things that happen while our men and women are on active duty to a time when they come off active duty. So I think this is great that we can both be here to do this in tandem so that it gives everybody a chance to kind of hear the pull-throughs, the things that happen early on and then later in life. All right, well, let me just start with a little bit of background with our military suicide prevention efforts and what in the Department of Defense, or the DoD, has been a cause of concern. So starting in about 2001, when we really started to track some very common data, we looked at suicide rates among our service member population. And at that point, the active duty service member rate for suicide rose from 10.3 to 17.6 suicides per 100,000 service members. So that was a steady enough increase starting around 2007, 2008, where our attention began to focus in on the problems with suicide. In 2009, Congress required a task force on suicide among members of the armed forces, and in 2010, the task force was stood up and given a year to report. So in 2010, the DoD task force report made 76 recommendations. The primary recommendation was that in order to get our arms around suicide prevention within the DoD, we should stand up a suicide prevention office. So by November of 2011, the Defense Suicide Prevention Office, DESPO, was stood up, and I became its first director. So what we've done is we've worked with the services, and we've led several efforts that promote help-seeking, resilience, and total force fitness. Total force fitness is an instruction that was developed by the chairman of the Joint Chiefs of Staff, which incorporates sort of a mind-body-spirit connection for resilience for all members of the armed forces, and we've even adopted it somewhat for family members. So in looking at risk and protective factors, and I'm on slide 4, one of the things we've looked at some of what does the VA and the CDC and WHO, what are all of the common understandings of suicide in the population at large, and then how do we look at that and discuss these warning signs in terms of the active duty Guard and Reserve military population. So when we talk about service members or their families, when we see key indicators, we look at things like when somebody is talking about or making plans to take their own life, putting their personal affairs in order. For example, one of the things we've seen and heard pretty often is that somebody will change their service member group life insurance policy. Sometimes they'll do that multiple times. They'll come in, they'll change it, they'll change their mind, they'll change it again. Sometimes they'll make it their mom, sometimes they'll make it their wife, sometimes they'll make it their girlfriend, then they'll change it back again. So there's some activity that goes on around their military benefits, changing beneficiaries, updating those statuses that sort of become a clue as to what's going on. Giving away personal possessions. We see people who deploy do that as well. Like if they have a motorcycle they really love, they will give that to somebody else for safekeeping. In terms of the suicidal behavior, we see some of the same things where people will give away some of their prized possessions. Abusing drugs and alcohol, we see that quite often within this population as well. It's almost as if they're testing themselves with this high-risk behavior, and they're doing things like drinking, driving, using drugs, going too fast, engaging in other very risky behaviors that might otherwise seem like fun activities, but there's this line that gets crossed. Acquiring, obtaining access to lethal means. We've looked at this mostly from the weapons and prescription drug perspective. Weapons are a key feature in military suicides. Most of our folks who have died by suicide have died using a personally owned firearm. So they have access to lethal means in that they have military-issued firearms, and if they're in a deployed setting, of course, we just assume in a deployed setting everybody has access to lethal means, because in places like Iraq and Afghanistan, everybody has a weapon. So that access has been a concern for the department, mostly along privately owned firearms, and there have been some legal statutes that have prevented the department from asking about personally owned firearms. However, the last National Defense Authorization Act, the NDAA, just made a change to that. My volume. So that the NDAA just sort of changed our authority to improve access to lethal means by allowing commanders as well as behavioral health specialists to ask about privately owned firearms. And then there are things we can do about privately owned firearms, because there are armories. You can check your weapon into any installation or Guard Reserve armory. So we're trying to get better about making people aware of the weapons issue and how you can mitigate risk with weapons. We have also engaged with VA on a program where we're promoting the use of and distribution of gun locks. So gun locks are a key here. And I've discovered very often when I've talked to family members that they're not even really aware of what a gun lock is, what it looks like. So that might be something to discuss in sessions with service members and families. It's just sort of, what's the safety plan? If there is a weapon in the house, what's the safety plan for that weapon? Because sitting down and making those kinds of safety plans could be a good thing to do as a way of really addressing the issues of being safe at home, whether it's the service member or a family member who might be suicidal, is to really have that discussion and sit down and map out a plan if there are weapons in the home. We also have done a lot around the prescription drug issue. Even though the majority of our suicides were not by prescription drug, a lot of our suicidal behaviors, such as overdosing and other self-harming behaviors, have been related to prescription drugs. So we've started to look at that and look at things we can do about prescribing and prescribing patterns, and working with providers to think about how much medication are they prescribing, how many refills are part of a prescription, use of blister packs, and then providing education on prescription drug disposals. So we're looking at like medication reclamation programs. So how do we take back the medication in a safe way? and I know the DEA is in the process of finalizing some of its regulations. We're working with them, as is the VA, on this drug take-back and disposal programs. Engaging in other out-of-the-ordinary risk-taking behavior, I think I kind of addressed that when I talked about the drug and alcohol. Anything that's obsessive, dangerous, is a warning sign that we're concerned about in terms of, and we have interestingly enough, we have within the Department of Defense, we have other offices that are safety related. So they also look at drug abuse, accident reports. There's quite a bit of issues with safety within the DoD and reducing on-base accidents, whether they be motor vehicle accidents, sports injuries. So the cause and effect of some of those risky behaviors gets looked at as well from more than one perspective. And then, of course, expressing helplessness and loss of hope are two key factors when we're talking about suicidal behavior. Risk factors for suicide, I'm on slide 5. Service members may be predisposed to taking their own lives if they have had a prior suicide attempt. So we're trying to get better at tracking suicide attempts, family history of suicide or mental disorder, relationship problems, which, you know, these are young people, sometimes with lots of life changes, disruption, decisions get made sort of rashly, so that for some of these young folks who first join the military, they may be leaving like a high school girlfriend for the first time. They may be changing stations, so they've been at Bragg and now they're going to Campbell. Those are disruptions to their significant other system that is often very hard on some of the younger service members who are not used to those kinds of disruptions, who aren't used to making those kinds of moves and changes, are away from home for the first time, so they've lost sort of their family of origin connections. And that's where we see some of the problem-solving issues and ability to adjust start to show themselves within the first year to 3 years of coming on active duty. Legal and discipline problems, we see quite a bit around guys who get what we call Article 15s, which are like misdemeanor type infractions, drunk driving, driving too fast, getting into fights, being absent from work without permission. So those are some of the smaller problems that become some of the bigger problems as we see a progression towards someone who may become suicidal. And I think it's important to maybe take a pause and note that suicide is complex. So there's not one of these things that we're going to talk about today is really a clear-cut trajectory towards somebody becoming suicidal. There are always going to be a multitude of risk factors that may lead someone to be suicidal, or there may be something that precipitates a very impulsive response to a bad situation. Like I had one of our general officers told me that one of his guys who he thought was great, you know, was the go-to guy, the happy guy. Well, he failed an exam he could have taken again for his military promotion, and was just so devastated by failing this exam that he shot himself. So I think thinking about that across a continuum, you know, I've often thought about this, and I've called it the snowflake, snowballs, and avalanches. Suicide becomes the avalanche at the end of the mountain when so many other things have gone wrong. The snowflakes are the things, and I think we all get a little bit of snowflakes in our lives, and then they may turn into snowballs, but we can manage those things. The snowball will hit you a little harder. Snowflake you can catch on the tip of your finger, but the real issues become, as those things collect speed and come down the mountain, how do they come together? So that these legal issues, these little issues, the being absent from work, the not being in uniform, these small problems that are administratively legal issues and discipline problems can then roll into some of these bigger problems. Other things we see in the military world is how a command climate, a negative command climate, can really impact somebody, and I think that fits in with relationship issues in some ways, because if your command climate is negative and you don't feel like you have the support of your commander, your first sergeant, your unit, your squad, your fleet, there are going to be impacts that roll through how you're going to be able to get help. If there's stigma and you can't feel like you get help, those all become cumulative factors in somebody's trajectory. Changes in personality or behavior, those pretty much, I think, speak for themselves in that we see people go through these moods and behavioral changes as they're dealing with the stressors and other problems in their lives. Financial problems, I think, have been a huge problem, not just for the military, but across our nation. Our economic climate has not been good, and I think that's just affecting everybody. And I think those financial problems spill into the military. We've seen Guard members who have lost their civilian jobs, and then they Guard hop. So they look for opportunities for deployments by joining units that they know are going to deploy. So somebody may be with the Indiana National Guard but has been in Afghanistan or Iraq with the Pennsylvania National Guard, the Texas National Guard, the California National Guard. So they're always looking for units that need their military occupational specialty and join that unit in order to deploy with them. And then, if they have family problems, like mom's house is being foreclosed on and they've tried to bail out other family members, they've gotten into deep water with their own finances as well. And then occupational problems, I think I've talked to some of that, about how that command climate can affect that, stigma can affect that, the inability to want to get help because of security clearances. Those issues have come up, even though we've only seen 1% of our service members ever lose their security clearance because of a mental health issue. It's still the concern that if you're going for treatment on medication, that you're going to lose your status somehow within the unit. Okay, I just wanted to make a note about post-traumatic stress disorder, PTSD. There's been a lot of concern back and forth about PTSD and the symptoms of PTSD, which are here. Since this talk isn't on post-traumatic stress, I wasn't going to really go into some of these things, other than to make note that there's some research that indicates that untreated PTSD can increase some suicidal behaviors, or some things that are associated with PTSD may look like suicidal related behaviors, and I think you have to be able to sort of sort out some of the anger and the rage, the hypervigilance, some of those behaviors associated with PTSD, and what those risks look like in terms of suicidal behaviors and thoughts. There was recently an article in JAMA, however, that I think is important to note, that was a collaboration of several researchers that looked at military data with national death record data, and found that male gender and underlying mental disorders, which were depression, bipolar, and alcohol misuse, were the strongest risk factors for suicide. The findings did not support some of the assumptions that we hear quite often, that specific military factors, such as number of deployments, combat experiences, are directly associated with increased suicide risk. So some of these findings are actually more consistent with civilian research, so that some of the increase in the military suicide rate they found might be more associated with the increase of prevalence of mental disorders in the civilian population and are more an indirect culmination of occupational stressors across deployed and home station environments over many years of war. So these findings suggest that current initiatives for screening and high-quality treatment for mental disorders and substance abuse have the greatest potential to mitigate suicide risk. So I think that's been one of the misnomers, is that the deployments and the combat stress have caused more people to be suicidal, which we're not really seeing that. More than half of those who have died by suicide while on active duty were not deployed, and I think it was like 89% had no combat history. But then among those who do have PTSD and have been diagnosed with PTSD, I think the risks for suicide are going to be different. Okay. I just want to take a moment, because I'm almost out of time here, on protective factors. The department has spent a lot of time looking at resilience. Most of the services have moved towards more of a resilience campaign portfolio, where they're looking at the total force fitness, that mind, body, spirit connectivity, instilling sense of purpose and belonging, teaching relationship building, trying to ensure stable environments, teaching values, encouraging service members and their families to participate in relaxation, hobbies, recreation. We have very much involved the chaplains so that the spirituality focus is part of our resilience campaigns. And then looking at things like problem solving, being goal-oriented, and then again, from the total force fitness, is the regular sleeping, eating, and exercise. We can certainly gauge all of that and focus on that within the military culture, because it is sort of a captive audience. This says wounded warriors, but this really does apply to all service members. So just a few closing notes on some of the things we've done within the department that have been suicide and resilience focused. I mentioned the task force. We broke the task force into priority groups. So we have really focused on developing policy. We did a directive. We're looking at group 2, data and surveillance. So we've worked quite a bit on those efforts to look at how does the suicide event report, the DODSR, how does that inform programs and policies moving forward? We've been developing a program evaluation approach that has mapped out the Army, Navy, Air Force, Marine Corps suicide prevention and resilience programs across the continuum, and we mapped that to the National Strategy for Suicide Prevention. We have worked on strategic messaging to reduce stigma. We've done quite a bit of that with the Department of Veterans Affairs. I mentioned some things about means reduction policy. We are looking at military training and developing core competencies for suicide prevention, so some of those risk and protective factors we discussed. Evaluating access and quality of behavioral health care. Access to care has been really seen as a way of reducing suicide and suicide behavior, is to address those mental health issues. So that's been really important. We also own our own death investigation process, so standardizing the death investigations, psychological autopsies, looking at actually also military families and their suicide rates have all become part of some of those activities, and then a comprehensive research strategy. We have developed a portfolio of about 80 different research studies that we have found relate to suicide and suicide prevention across the department, and we are looking at how we can do some translating of those studies. Again, the directive, I think I mentioned, the Suicide Data Repository is a joint effort with VA to understand those issues. Our own program evaluation, the Military Crisis Line campaign, I think Caitlin's going to talk more about that, so I won't go into that now. We just put together a military family guide. You can get some of our materials off our suicideoutreach.org website. On slide 11, Partners in Care, again involving the chaplains. The SF-86 is in relation to security clearances and making sure people know that if they say yes to post-traumatic stress, military sexual assault trauma, that will not impact their careers. The gun locks, the lethal means, the drug take-back, and then we did do a separate study on just the Guard and Reserve looking at what their needs were. We have done some things on postvention with the reserve components, trying to make them more aware of what's out there. The TEARS team is a bi-weekly call. We look at suicide research and we look for the ready right now issues. The Vets for Warriors, you can, again, also through our suicide outreach, you can link to that. That's a peer support counseling program that's available 24/7 that will help service members, Guard and Reserve included, with decision-making and problem-solving, and then refer to other resources within the DoD. And the National Suicide Prevention Strategy, again, was developed through the Action Alliance, and we are mapping to that. We have some activities that will continue throughout 2013 and beyond 2013. You can see some of those here. I think some of the things that we're really excited about getting more involved with is the therapeutic sentencing techniques, looking at the Veteran Treatment Court model for those that have legal difficulties, the Action Alliance and continuing to work with the Military Vets Task Force, and then expanding peer support and resilience-based programs throughout the department. That's my contact information on the screen. That's our military crisis line, which I think Caitlin will address. And then our suicide, so suicideoutreach.org is our website, and that has other information on it. So hopefully I've stayed within my time. And Caitlin, do you want to go next, or do we want to do questions, or were we going to do those at the end?
I think we'll do those at the end.
Okay, great. So over to Caitlin.
Thank you so much, Jackie. As Jackie said, it's really a pleasure to be here and speaking with you all today. So much of what you are training to do and so much of what you're going to be doing is going to be checking in with patients and seeing if they're okay. So, and suicide prevention should always be a part of that and be in the back of your mind. So even though we're talking today specifically about veterans and service members, all of this can be translated to your own patients that you see and that you will be seeing. So Jackie talked a lot, which I'm so grateful for, about some of the signs of those who may be at risk for suicide. What I'm going to do is give you an overview of what the VA is doing and speak a little bit about some of our specific resources that we have, and especially a couple of resources that we have that are specific to those of you who work in the community and will be community providers. Okay, so looking at this first slide, I just want us to note the It Matters campaign. Every year we have a different suicide prevention campaign. That last year was Stand By Them. The year before that was It's Your Call. And this one is It Matters, because one small act can make the difference. So your life matters, calling matters, everything supporting others matters. Just looking at the percentage of our veterans today. So Jackie spoke primarily about service members, and so once service members are separated from the military, they become veterans. And we have about 21.8 million veterans in the U.S., still predominantly male, 93%, 7% female. Of course, that number is rising as more and more women separate from our more recent conflicts. If you look in the far right-hand corner for the service era, as you can see, most of our veterans are still our Vietnam-era veterans, at 32%. We're still seeing about 7% World War II vets, Korean War vets, 10%. The World War II veterans, they die at about 1,000 veterans a day. So we're seeing less and less of them, but I really want to note the importance of older veterans. So much of our energy, and understandably, is spent with looking at our veterans from our more recent conflicts in Iraq, Afghanistan. But it's especially important to really consider our older veterans, because older men still have the highest suicide rates overall in the country, and that's very similar in the veteran population. Older men, especially those who are 80 and older, 65 and older is still a higher percentage, but especially 80 to 85 and older have very, very high suicide rates. And the primary reason for that is because they use guns, and especially veterans. Veterans, as Jackie said about service members, but as they become veterans, they still really hold on to their weapons. So much of what we do, and so much of what we hope you'll do when you see veterans especially, but anyone, is really to look at gun safety and really framing it as a way of, we need to keep you safe. How are you going to keep yourself safe, even though you still have a gun, and we don't want to take away your gun, but we want to talk about putting the ammunition in a separate locked box, especially if they're in crisis. Overall, veterans are more likely to die by suicide than the general population. The percentage of veterans in the U.S. population is about 1%, but the percentage of those who die by suicide for veterans is 20%. So out of the general population, out of the 38,000 or so individuals who die each year by suicide, 20% of those are found to be veterans. And here are some of the suicide rates from 2009. As you can see, this is across age. And as you can see, as I said, the percentage really spikes at about that mid-70s and older population for men, but men still tend to have very high suicide rates, male veterans. Now we're finding between the 30 and 50-year mark. Really want to focus, too, on female veterans. We are doing a lot of outreach and work with our female veterans. We're really restructuring our VAs to accommodate our female veterans. But you may see a lot of female veterans because some of the VAs aren't quite caught up yet. And we have found that women veterans also have higher suicide rates than the general population of women. Suicide rates among VA users. So much of what we try to understand is what these rates look like for veterans overall, but it's very hard to do. And so one of the things that we're doing, and as Jackie said, we are doing a lot of collaboration with the DoD on this, is our suicide data repository, and just data in general. We're trying to get information from the states on and looking at coroner's records and looking at the National Death Index and working with the CDC. But overall, we're really able to speak to those veterans who use VA services. And the total rate of male veterans out of 100,000 in 2009 was 38 men per 100,000 died by suicide, and those, again, are VA users. So we're still looking at so much of this data. We're trying to understand more. We are finding, though, and this is encouraging, that over time, especially up until 2012, there's been a decrease in what we call non-fatal suicide events in the VA, and what those are suicide attempts. The VA's approach to suicide prevention is one that has been really seen as a model for suicide prevention across many different healthcare systems. And what we want is ready access to quality care. We want to get veterans and service members and anybody who, but really anyone, but we believe that getting them immediate access to care is important. So how do we get that? What are our access points? We have the Veterans Crisis Line or the Military Crisis Line, which I'll talk about in a second. We have what are called suicide prevention coordinators. We have at least 1 to a team of suicide prevention coordinators at every VA across the country. And those are our local experts in suicide prevention with veterans. And I'll speak about them just in a bit. We do a lot of PSAs, a lot of outreach. Our suicide prevention coordinators are required to do at least 5 outreach events per month within their local community. So that can range from providing information to local gun shops about suicide prevention that they can just have out for people who are purchasing weapons. We go to different Native American tribes, and we'll speak about suicide prevention there, as they have very high suicide rates, especially Native veterans. And also a lot of, we'll go to NASCAR events, they'll go to baseball games and put up a table, and just so that there is an awareness of what the VA is doing and how the community can get involved. So if you have a specific interest in suicide prevention in whatever school you're at this point, I can show you how to get in touch with your local suicide prevention coordinator in that area, and they can perhaps come and do a training on a gatekeeper training that we do for suicide prevention for veterans, which is called Operation SAVE. SAVE stands for Learning the Signs and Symptoms of Suicide. Again, Jackie went over those. So most of those that she spoke about for service members are the same for veterans, and very much the same for individuals in general, especially hopelessness. Then A for the Operation SAVE is asking the question. One thing that I'm hoping that you're learning in med school, or if you're not, it's one thing that you can teach others, is the importance of being able to use the words, are you feeling suicidal, or are you feeling like killing yourself? Asking it very directly and not being afraid to ask the question. Many people are scared, well, if I ask the question, it's going to put it in someone's head, and then they're going to kill themselves, because I suggested that they might be by asking them that question. And that is not the case at all. Anybody who is suicidal is already considered suicide. And by asking the question, you're not closing the conversation down, you're in fact opening it up, because your patient is going to say, wow, that person is concerned about me, and I can speak about what might be the most painful emotions that I'm feeling right now. So again, with Operation SAVE, it's the signs and symptoms, asking the question. V is validating the experience, saying, wow, this sounds like you are really coping with a lot right now. Let's talk about how we can keep you safe. Let's take you to the emergency department. Let me give my mental health people a call. Let's call the crisis line, and then expediting care. So our suicide prevention coordinators and others will go out into the community and provide this Operation SAVE training. They also provide it to every new clinician at the VA and actually every employee who comes into their VA is required to take Operation SAVE. We also have a couple of research arms in the VA, our Center of Excellence up in Canandaigua, New York, which looks at suicide prevention with veterans from a public health perspective and epidemiological perspective, and our MIREC, our Mental Illness Research Education and Clinical Center out of Denver, is also looking at suicide prevention more with intervention as their angle, looking at TBI and PTSD too, so traumatic brain injury. The Veterans Crisis Line is a 24/7, 365 service, and we have been up and running since 2007. See in the far left, we first started calling it the National Veterans Suicide Prevention Hotline. In 2010, we rebranded it to be the Veterans Crisis Line because the purpose is we want to get to veterans before they're suicidal. If they're in crisis but they're not yet suicidal, we want to preempt their feeling suicidal. In 2011, we double branded it, as Jackie said, to become the Military Crisis Line. And it's the same crisis line. It's the same responders who take the calls, but we want both our service members and our veterans to feel comfortable to call 1-800-273-8255. And if you press 1, all of those calls are routed up to the Canandaigua VA Medical Center. We now have up to 300 staff members. They're all VA employees. Those who are taking the calls, they're all mental health professionals and all have a really solid understanding of veteran and military culture. We also have an online chat service that I'll show you how to get to. Texting service we started in 2011, and we now have a new mobile site. We've actually taken now over 1 million calls since 2007. We get about 1,000 calls a day, and in many ways that's heartbreaking, but in most ways it's so important because people are reaching out. And so if you're with a patient and someone is saying that they're suicidal, they're a veteran, or a service member, and you're not sure what to do, you're suddenly going blank as far as what you're supposed to do next. We've had physicians call us. We've had psychiatrists call us who say, I need someone to do a suicide risk assessment. We're able to do that on the phone and really help to then decide what steps need to be taken next. Our suicide prevention coordinators, again, they do direct care. They provide outreach and education. They're the ones who do our reporting and tracking of those suicide events, whether they're fatal or non-fatal at each VA, and they do a lot of monitoring and oversight. So we also do a lot of connecting through VA with corporations, CSOs, faith-based organizations. Of course, we're doing a ton of work with the DoD. I'm going to show you where some of your public service announcements are found. Campaign materials, if you want to have some of these materials in your office. So when veterans come in or military service members come in and sit down and you're worried about them being in crisis, you can provide them some of the materials that we have through your local suicide prevention coordinator. If you go to veteranscrisisline.net, there's a site where you can download web ads, print materials, so that you can just print them out yourself and hand them out so that people can have materials about both the Veterans Crisis Line and the Military Crisis Line. This is where you can find your resource locator. So if you're not sure where your local suicide prevention coordinator is, or where your local VA is, or your outpatient clinic for veterans, vet centers, VBA offices, or crisis centers, on veteranscrisisline.net, there's a resource locator. You just put in your zip code, and you'll have all of that information. Out of the resources here, the one that I think is going to be most important for all of you, and one that I hope that you just visit just to check it out, so that if you need it in the future, it's there for you. But we've established what we call a mini clinic, and that's an online resource for all of you, for community providers, unless you're working within the VA, on tools and information. It's a toolkit on how to treat your veteran patients who may have a variety of mental health conditions. So there's a section on serious mental illness. There's a section on PTSD, on TBI, and there's a specific section on suicide prevention. And so if you go to the site that is at the very bottom of this slide, if you open it up, go to suicide prevention, and it'll provide a lot of the information that I've provided and more. So we are really proud of that resource because we really want to ensure that we're partnering with our community providers and our community physicians, because we know that less than half of all veterans still only use VA care, and the rest are going to be coming to you. And so you need to understand the veteran culture and how to work specifically with veterans, particularly with the more signature injuries that they are coming home with or that they've had over time. I also encourage you to go to maketheconnection.net and just play around with that site, the site that you can then sit down with your veterans or family members to look at challenging life events, mental health conditions, suicide prevention. The site, you can actually tailor the site to your own experience. So I could go on there and I could say, I am a male Vietnam veteran who saw combat. I hit enter, and all of the videos that are going to be shown to me are of other Vietnam veteran era veterans. And it has been shown to really lessen a lot of the stigma of people who are saying, and especially veterans and service members who say, I'm the only one who this happens to. They can then go onto this site, tailor this experience, and say, wow, that person looks like me, they sound like me, and I'm going to reach out for help because that's what this person did. Some more information about PTSD is there for you, and our veteranscrisisline.net is also militarycrisisline.net. It's the same website. There's a specific section for military members, and also know that the Veterans Crisis Line or the Military Crisis Line also has lines both now in Korea, in Europe, and in Afghanistan, so that those service members can reach out to the Veterans Crisis Line from those areas. So that's all of my information. I'm very available and happy to answer any questions that you may have after this talk is over. But I think that we want to leave these last 10 minutes or so for questions for either Jackie or me. And it's just been a pleasure talking with you.
Great. Thank you so much for your presentations today and for providing such great resources. We will open it up for questions, and Anita is going to kick that off.
Great. So we had a couple of questions come in throughout the presentation, and I'd like to start with what are the differences between the Reserve, National Guard rate of suicides and risk factors that might be different from what you presented about service members or veterans? Are there differences?
Sure. We know that the Guard and Reserve, because of the nature of their how they're composed, is very different than the active duty. They are, in some cases, more rural, more remote. They're not installation-based. They're more integrated into their communities. So they're less likely to get the word through the military channels. Because they're not on installations, they're not just going to wander over to the, for example, like the Army Community Family Center and be able to just drop in on resources. They also are more affected by unemployment. I think I touched on that when I said we have members of the Guard that will, unit shop and look for different ways to deploy. That's very much motivated by the economics of otherwise being unemployed, except for when they're drilling with the Guard or Reserve, and that would be the only time they're actually getting paid if they don't have a civilian job. So we've set up some very specific programs, though, that are focused on the Guard and Reserve, like the Yellow Ribbon Reintegration Program takes place before, during, and 30, 60, and 90 days after, so that service members could learn more about their benefits and what to expect. The ESGR, Employment Support for the Guard and Reserve, is a program that works with employers who have members or workers who are deploying, protect their USERA, the Uniformed Services Employment Rights Act, their ability to work on programs that can help service members maintain their employment status even when they've deployed. So those kinds of efforts and programs are geared and tailored very specifically for the unique challenges of the Guard and Reserve.
Thank you, Jackie. Caitlin, I think this one occurred during your portion of the presentation, and the question is, are the statistical numbers that you presented based on soldiers that are still active in their units, or does it include those who have left already? So there was an anecdote about a couple of people who had left the military in a particular state and had committed suicide. So could you clarify that for us?
Sure. So all of the numbers that I presented are those who are veterans, and especially those who are in VA care. So those are no longer still active in their unit. And as far as the having experienced 3 suicides, with 2 of them having left the military, if they've left the military, then they would be included in our data.
Yeah, I think what we've done with a suicide data repository is VA and DOD have worked together to look at the National Death Index and then what our own sort of repositories and data sets had in them, so that we're trying to be inclusive so that we're capturing all deaths. But we also don't want to be duplicating service members and who are veterans, and that will mostly come with the Guard and Reserve, whether they die on an active duty status or like in a Title 32 status. So there is some potential risk to overcount or double count, and that's what we've worked really closely on, is just making sure that when we're counting them as service members or veterans, that we're doing it with a clean mark of demarcation, if that makes sense.
Thank you. I think some of our questions were covered, they were asked as we were going through the presentation, and they've been covered about reaching people outside the scope of your organization. So I'd like to tackle a question about how we're treating depression as sort of a co-presentation of suicidal behavior or thought. So there's a question about all of the different commercials and advertising about drugs on the market, and depression being a common side effect of those treatments. So the question is, are we looking at these drugs pre- and post-deployment as contributing to these depression issues?
So, you know, I think with any medications that where there are these side effects, you know, some of the side effects that you'll see on TV will also say increased risk of suicide, and so it's possible. I think that I don't know of any. I know that there are a lot of drug studies that are going on throughout VA. I'm sure with DOD as well, to look at specific medications that are being used, especially for service members and veterans when they are depressed or that may contribute to depression. I know there's one study right now that has just started up to look at lithium, but to look at that as a suicide, as helping to prevent suicide. So I think just in general, this is something that you just need to be aware of and be careful about, and just note that if this is a side effect for depression, then you have to ask about it and really follow closely as time goes on.
Yeah, thank you. So the person who wrote the question also shared that as a veteran, he or she returned from Iraq and was plagued with depression, and so I want to thank that person for your service to our country. And the person went on to remark that, you know, kind of asking around other people in similar situations, a lot of people experience this symptom. And so I want to know if you'd like to return to your point about isolation and underscore anything there for folks at all.
Well, I think that looking at depression in isolation of other diagnoses or other factors is, as I said earlier, this is a complex issue. So I think we can't just look at one thing and try to pinpoint this one thing that is a cause or, you know, that results in suicide. Depression is also a symptom that can be associated with post-traumatic stress disorder, with substance abuse, there's a whole spectrum of bipolar disorder issues, and some of it is adjustment issues. It's related to grief. So depression in and of itself really needs to be, I think, parsed into some of the associated causes and other diagnoses or other situations that might be going on in somebody's life. And then in the context of, is somebody suicidal, I think then you need to look for some of these other risk factors that we associate with suicide or suicidal or self-harming behavior.
Yeah, and I think also what this touches on too is reintegration. And I know that the DoD and VA, but the DoD especially, is being very, very aware of reintegration concerns and really helping through a number of different initiatives to help with that reintegration because it just can be so difficult, and it can then bring up feelings of depression and, you know, and just readapting to the life that one perhaps had otherwise.
Thank you. We're almost at time, and I would just like to conclude with any sort of final thoughts you have for physicians, medical students, residents about any takeaways from what you've presented today that you would especially like these members of our audience to know.
Well, I'm going to speak for Caitlin and I. Take that 1-800 number, 273-8255, press 1, and really, if you call it the Veterans Crisis Line or the Military Crisis Line, put that near your phone, keep that handy-dandy, because when in doubt, that's what that number is there for. Get the help, get the advice, get the guidance if you need it, whether you're a provider, a veteran yourself, a family member or a veteran, or just have questions. I think that is probably one of our greatest resources right now, is the 800 number.
And with that, we'll conclude today.
I just want to say thank you to Ms. Garrick and Dr. Thompson for sharing your expertise on this important topic. Tomorrow's webinar will focus on military sexual trauma, what civilian providers need to know. Thank you to our participants as well, and we encourage you to complete the survey that follows this webinar. Thank you.